everyone. We continue with the guest lecture on gastroesophageal reflux disease and functional dyspepsia overlap. Chairing this session are Dr. Indika Botheju and Dr. Barana Millavithana. Over to you, sir.
Good morning. I'm Dr. Barana Millavithana and my co-chair is Dr. Indika Botheju. Both are general internal medicine physicians. It is a great privilege to introduce Professor V.G. Mohan. Professor V.G. Mohan, he has a vast experience in the field of gastroenterology, and he was the past president of Indian Society of Gastroenterology and Gastrointestinal Endoscopist in India. And he's an adjunct professor in Tamil Nadu Medical University, and he has received so many awards in the field of gastroenterology. Let me introduce Dr. Professor V.G. Mohan to give us a talk on GERD and functional dyspepsia overlap, conquest of the maze. Over to you, sir.
Most respected chairpersons and the president, Dr. Suranga Malingama, and my dear friends here. It's really an honor to be back here in Sri Lanka again. I was there last year and they've invited me. You have invited me this year also. I'm very, very grateful. So the first talk is on GERD and functional dyspepsia overlap and conquest of the maze. So this is the Villa Paisani labyrinth in Italy. Very difficult, one of the most difficult mazes to conquer. So that's why I just put this up. And in a clinical scenario, the GERD, functional dyspepsia, irritable bowel syndrome are not watertight compartments. So I'll show you an example. This patient came to me and, you look at this. He has throat burn, heartburn, regurgitation. He has got abdominal bloating, early satiety, gastrocolic reflex. So there is GERD, there is dyspepsia, there is IBS. It's an overlap. This is what we see in clinical practice. And believe me, my friends, you're all physicians. And you will understand that when you go for your practice of medicine, by far the commonest type of patient that you see is all the GI patients. So that is why this talk of how to overcome this maze. So overlap is very common and making accurate diagnosis challenging. So, and this functional dyspepsia and GERD, there is a overlap in 2/3 of patients of functional dyspepsia have GERD. And again, within functional dyspepsia, there are two subtypes, the postprandial distress syndrome and the epigastric pain syndrome. They both also overlap. So what is GERD? It's a motility disorder where the amount of gastric juice that refluxes into the esophagus exceeds the normal limit, causing symptoms with or without associated esophageal mucosal injury. So the burden is very high. It's close to 15%. And the pathophysiology is complex. It is just not the acid, my friends. There are so many things that happen. Starting from, I'm sorry, one second. Yeah, maybe I'll show here in the pointer here. This is better. There is an, lax ileus or a hiatus hernia. And there is an impaired mucosal defense in the esophagus. Salivary bicarbonate could be low. Esophageal acid clearance is low. And then there is a gastroesophageal reflux, duodenal-gastroesophageal reflux, and all those things added together cause symptoms of gastroesophageal reflux disease. And the GERD can present with typical symptoms, atypical symptoms, or complications. Typical symptoms is with or without esophagitis, the heartburn, the regurgitation. That is a marketplace, a common type of cases that you see. But atypically, so many other symptoms, right from non-cardiac chest pain to hoarseness of voice to cough to so many things can happen. I'll show in the next slide. And of course, we need to know if there are complications right at the time of presentation, esophageal erosions, ulcers, stricture, Barrett's, esophageal adenocarcinoma. So we need to stratify the GERD patients based on severity of symptoms, recognizing those with atypical symptoms and those with a possibility of developing complications. So there are three clusters of GERD patients: the inconveniencing, that's by far the commonest, distressing, and disrupting. the one that disrupts the quality of life. So 1/3 of them are disruptive GERD. Very important to treat these properly. Again, based on the typicality of symptoms, I told you typical or atypical symptoms, and atypical symptoms starting from otitis media, asthma, sinusitis, dental erosions, aphthous ulcers, halitosis, pharyngitis, laryngitis, laryngospasm, postnasal drip, frequent throat clearing, globus sensation, tracheobronchitis, cough, chronic cough, aspiration, pneumonia, even pulmonary fibrosis, chronic bronchitis, bronchiectasis, non-cardiac chest pain, and sleep apnea. My friends, all these are the atypical symptoms of GERD. I'm sure if you see a patient in your clinic, it may be a combination of many of these. So just have your eyes open, and probably you'll be able to make a good treatment for a patient who has this atypical GERD. Well, if you take 100 patients of gastroesophageal reflux disease and do endoscopy, what do you see? 60% you don't see anything. It's nothing. It's normal. That is non-erosive reflux disease called NERD. Then the other situation is the erosive esophagitis, 35%. And then the complications. So advanced endoscopy imaging like narrowband imaging of Olympus can easily differentiate normal squamous epithelium from gastric epithelium, which appears brown here, and the squamous epithelium appears blue-green. So what is dyspepsia? Dyspepsia is indigestion. Dys and pepse. Dys and pepse is difficult digestion. So it's a disorder. What is a functional dyspepsia? Functional dyspepsia, where in a dyspepsia no organic cause could be found. How prevalent? Very prevalent. It's about at least 15%. Again, I told you the overlaps do occur, and the functional dyspepsia has been defined by Rome 4. So we need to go to Rome 4 for epigastric pain syndrome. This is a classic Moynihan syndrome. You think the typical history of peptic ulcer, abdominal pain, burn, after food everything goes down. Or I wake up in the middle of the night with hunger burn. You do endoscopy, no ulcer. This is typical epigastric pain syndrome, the so-called Moynihan syndrome for seniors like me. And then there is something called a postprandial distress syndrome. So where there are three components are important. One is fundic accommodation defect. So with little food, they are satisfied. Early satiety. I have the hunger, but I eat little, I'm full. This is typical of fundic accommodation defect. And I feel bloated. Even after 3 hours, 6 hours after taking food, I don't have an appetite. My stomach is full. This is postprandial distress syndrome, which could be because of gastroparesis, which could happen in diabetic population. DG is one of those important causes. And then there is functional outflow obstruction. So FOO. So where the pylorus is spastic. I'll show you some examples of these cases. So pathophysiology of functional dyspepsia is a delayed gastric emptying, impaired accommodation, hypersensitivity, H. pylori infection, CNS dysfunctions. And stress, my friends, can aggravate the functional dyspepsia. For example, you're going for an examination. Your mom makes some bread slices, so 4 slices. One slice, you say, I'm full. But after you do your exam well, and even 10 slices of bread, you'll ask, Mom, I want more. This is typically because of the neuromedian U release because of a reaction to stress, because of CRF getting released from hypothalamus. So the fundus does not expand to accept more food, my friends. This is very much possible in a case of functional dyspepsia if somebody is stressed out. So this is important to recognize. So this is the defective fundic accommodation. So what about the clinical scenarios? There's a 35-year-old gentleman who came with burning chest pain of 9 months. The pain and the burning was more at night, and he was not happy with PPIs. So we took him off PPIs for 7 days, put him on sucralfate and alginic antacids, and then took him up for endoscopy, manometry, impedance, pHmetry. This is what happens. This is a hiatus hernia. So it's wide open. And then C, this is grade C reflux esophagitis. And so severe erosions. This is called erosive esophagitis. This is disruptive GERD, which disrupts the quality of life. We did manometry. We found there are 2 levels of the LES and the hiatus. So, and it's weak. So this wave pattern, anything below this dotted line here indicates that too much of acid coming in to the esophagus and staying for long periods. And the longest episode was at night for this gentleman, which crossed 3 hours. The acid was staying in the esophagus for more than 3 hours at night, producing all this damage. So we gave a PPI prokinetic combo. He was felt better, but he wanted something definitive. We went ahead and did a laparoscopic Nissen fundoplication, and he became completely all right. A second case of 26-year-old male with throat burn, heartburn, regurg, early satiety, and postprandial distress. The same case that I showed you at the beginning. This is how the esophagus looked. There is a laxity of ileus, but look at the pylorus. It's spastic. So we did electrogastrography. Just like you do an ECG, we do an EGG. So there we found that, this is the upper normal, lower normal limit of the community normal, and 3 CPM, 3 contraction per minute activity of the stomach. The patient's graph is much above that, indicating there is a functional outflow obstruction in this patient. So there's a delayed gastric emptying because of FOO. So we treated with prokinetics. He felt better, but then still symptomatic. A simple thing of endoscopic pyloric balloon dilatation completely reverse the whole process. The next morning, the patient had no more symptoms. So there's a 50-year-old female with the bloating and nausea and vomiting, stale food at times, obviously showing there's a delayed gastric emptying, gastric scintigraphy, 303 minutes, T-half. T-half has to be less than 90 minutes. It's 303 minutes. Food is staying for long inside the stomach. So we took her up for a G-poem. So G-poem is we make a tunnel in front of the pylorus and then go ahead and dissect the pyloric sphincter, which is spastic, and then put clips and come out. So it's all done perorally. It's called a gastric poem. And so this patient had a hiatus hernia, GERD, gastroparesis, delayed gastric emptying, and then the patient became much, much better once we did this G-poem. I think for want of time, I'll skip this video. So pre-G-poem and post-G-poem. Pre-G-poem, even several hours, the barium is staying here. But post-G-poem at 45 minutes already, it's in the small bowel. So how do you manage GERD and functional dyspepsia? The goals of therapy of GERD are multiplex. One is you prevent acid from going up. You improve the gastric emptying. Increase the pyloric sphincter competence. If it is tight, relax it. So esophageal clearing capacity is improved by prokinetics. You coat the inflamed and denuded tissues with sucralfate and augment the ileus, and then reduce the volume of acid and also the pH of the acid to be increased. All this has to be done. So it's a stepwise approach, control of symptoms, and then prevention of recurrent esophagitis and complications, secure a diagnosis of GERD, explain, reassure, educate, diet and lifestyle, weight control, because once you lose weight, once the truncal obesity is gone, the reflux and erosive esophagitis also goes down. So treat to target and refractory disease management. That is the disruptive GERD. So lifestyle, very important. Say no to all. So one of those youngsters who came to me was totally depressed when I said everything has to be avoided. No alcohol, no smoking, no citrus fruits, no coffee, no tea, no chocolate, no vanilla, no banana because vanillin there, no fried food. And I said, is it worth living? I said, don't follow it like an army style. You have to go low on them. That's about it. So you can definitely control. And then, of course, the time-honored PPIs are the mainstay. H2 blockers have no role. You combine a prokinetic with the PPI because now today, the complications of long-term PPI use are coming up slowly. And then we tend to de-prescribe PPI as per the Canadian Gastroenterology Society recommendation. So we add a prokinetic. If there is reflux, it works wonders because our diet is different from the Western diet, which is very bland, whereas we take more spicy, oily, fried food with a lot of masala, then everything keeps coming up. So PPIs all are same and H2 blockers have no role. And now The acid pocket is one problem, that in the fed state, after the acid mixes with food, there is more. If there is more acid, it can float. And so the pH, which is very close to the OG junction, is low pH, acidic pH. So the first thing that refluxes is the acidic pH juice. So this can be countered by raft-containing antacids. And then, of course, disruptive GERD, and beware of the mimickers. So many things can mimic erosive reflux disease, non-erosive reflux disease, acids, hypersensitive esophagus, non-acid hypersensitive esophagus, functional heartburn. So many categories are there. If a patient of GERD is not responding to PPI, then you break your head. Is it one of those subsets that you're looking at? So we need endoscopy, manometry, impedance pHmetry. This can easily solve this problem and give you a proper diagnosis. So PPI prolonged use and PPI resistance is well known. On PPI, 40% of them do not respond. And there is a nocturnal acid breakthrough. 75% of the patients are refractory to once a day PPI, and if you give double dose PPI also in the night, they still wake up because of heartburn. See, this is a typical nocturnal acid breakthrough that happens. So you can add a H2 blocker at night, or now go for vonoprazan. Vonoprazan, is it available in this country? Vonoprazan is available? Is it? No. Okay, so this is a potassium competitive or potassium channel acid blocker. Very good drug. So when compared to PPI, you can take it before meal or after meal, doesn't matter. And you can also take it at night because it can suppress the nocturnal acid breakthrough. So it works well in disruptive GERD. These are all trials which have compared head to head PPI with vonoprazan and has shown it to be useful. So how to manage a GERD-FD overlap, the last part. The PPIs are the mainstay of treatment in the management of GERD and functional dyspepsia, epigastric pain syndrome. Somebody has a stomach burn, epigastric pain, typically like EPS, no ulcer, but has also reflux. Treat with PPIs and prokinetics. PPI prokinetic is a winning combo in functional dyspepsia, GERD overlap. So GERD related dysmotility is very well known here. The gastric pacemaker is here. See, from here it initiates a 3 CPM activity, 3 contractions per minute activity. So if the foot stays here and doesn't come down to touch the pacemaker of the stomach, then it keeps refluxing upwards in GERD. Then it doesn't cross the pacemaker, so it doesn't get carried down. So if there is somebody with GERD and a delay in the gastric emptying, if you augment the LES by doing a surgery or endoscopic augmentation of LES or use a prokinetic, it can solve this issue. So a rationale of combination therapy of PPIs and prokinetics have been well published. So these are all the prokinetics: domperidone, metoclopramide, levosulpiride, etopride, acoshamide. Acoshamide is the drug for fundic accommodation. If, as I told you, if the neuromedian U is overactive because of corticotropin releasing factor from the medulla stress, use acoshamide. It can relax the fundus. Etopride is useful for all purposes, and levosulpiride if there is no Parkinson's disease in the family and not an elderly gentleman, then you can try levosulpiride, works well. And of course, metoclopramide we use less and less. So choosing the right prokinetic based on symptoms is very important. Functional dyspepsia, this is the algorithm. So first thing that today we need to do in functional dyspepsia is check for H. pylori. If it is there, eradicate it. And it takes about 3 to 6 months for the symptoms to resolve. So just with the eradication of a 10-day or 14-day bismuth quadruple or triple doesn't mean that immediately the patient will become completely cured of his problem. You'll have to wait. So you subclassify epigastric pain syndrome and PDS, postprandial distress. Here, PPIs are the mainstay. Here, combination with prokinetics will help. So to summarize, my friends, upper GI dysmotility have significant prevalence in clinical practice, hampering quality of life. Significant overlap exist between these disorders and make diagnosis difficult. Prokinetics are the drugs of choice for prompt symptomatic improvement in GERD and also in FD-PDS. Safety profile of prokinetics plays a critical role in choice of the right prokinetic. PPIs are the mainstay in treating GERD and FD-EPS. And potassium competitive acid blockers, the PCABs, vonoprazan, they're new kids in the block and marginally superior to PPIs. And when it comes to the question of eradication of H. pylori, they're 10% superior to S-omeprazole or even lansoprazole. So these are all two books that I released in India. So these are beautiful books on acid peptic disease, and the latest, right now, we have issued this pocket book of drugs and therapeutics in gastroenterology. So, which is very useful for postgraduates, physicians, and gastroenterologists. I thank one and all of you for your kind attention, and my greetings from our Institute of Gastroenterology at Coimbatore, Tamil Nadu, India. Thank you so much.
Thank you, Professor Mohan, for that excellent and very interesting lecture. May I invite you to the table, and I'm sure he will be happy to answer any burning questions. Few burning questions, please.
The question is on ranitidine. Is it still in use or not? See, what happened was ranitidine is a good drug. It's, of course, originally, at least 60 years old, and it's safe drug. Unfortunately, what happened was when in the United States, the US FDA picks up some samples of tablets from the shelf of the pharmacies and keep checking them for their potency as well as their any inadvertent contaminants. So there they found that nitrosodimethylamine, the NDMA levels up to 7 parts per million was acceptable. This is slightly above that range. So then GSK withdrew the product, Zantac in the US. They withdrew it from the shelf and they put it for rigorous testing. So that is why it was withdrawn. It was not banned by FDA. In India, the Drug Controller General, took samples from all the products. In India, we have probably 20 rabiprazole brands or 10 ranitidine brands. They checked and they did not find any increase in NDMA levels. But remember, even the chlorinated drinking water can provide more NDMA than a ranitidine tablet.
Yeah, one other burning questions for Prof. Mohan. When are we going to, refer to a gastroenterologist for upper GI endoscopy for these patients? Functional dyspepsia is very common. What is your opinion on that? So how far can we wait without, with treating only pharmacological?
A great question from the chair. Like a patient with GERD, do all of them need an endoscopy? Not really. If the patient is young and typical symptoms of GERD not disruptive, you can straight away put them on PPIs. And the American recommendation is twice a day PPIs for 8 weeks. At 4 weeks, you call him and ask him, how are you? If he's doing well, continue. If it is 8 weeks, patient is fine, then, this is GERD, you can continue treating. You can slowly, what you can do, Canadian Association gave a beautiful suggestion. Like day 1, you give PPI, day 2, you give H2 blocker, day 3, PPI, day 4, H2 blocker, like that. You can, reduce the dose of PPI, add a prokinetic if there is symptoms of regurgitation, acid eructations, add a prokinetic, reduce the dose of PPI, and you can continue indefinitely. The other thing that you can do is on-demand therapy. The PPIs take about 3 to 7 days for a steady state level, whereas vonoprazan, 1 hour, it can reach pH of 4. Within 1 day, it can take the pH to 7. So very quick acting, so you can intermittently use it on demand.
Yeah, one quick answer, please. Now, is there a place for non-GI medications like anxiolytics and antidepressants for functional dyspepsia?
Absolutely. Yeah, because we need to use them wherever the patient is hyperanxious.
Thank you, Professor Mohan, for the excellent talk. I kindly invite my co-chair, Dr. Indika Botejo, to hand over the token of appreciation on behalf of the college.